Ready? Silent. Ready?
A very good evening to one and all. On behalf of Apple Hospital, Kadambwadi, Kolhapur, and on behalf of Apple Education Life, myself, Dr. Shriya Gadve Hanam Shetty, consultant physician working in Apple Hospital, as well as on behalf of our chairman, Dr. Ashok Bhupadi sir, we want to thank you सर्वांना खूप खूप नमस्कार आणि धन्यवाद, कारण तुम्ही पाठवलेल्या केसेस मधून आपले फर्स्ट 4 लेक्चर्स जे झाले. फर्स्ट वॉज अप्रोच टू अ केस ऑफ myocardial infarction. Second was approach to a case of hypertension. Third, ABC of CBC. Fourth, I presented myself approach to simple cases of diabetes mellitus. तर या सर्व केसेसचा ट्रेमेंडस रिस्पॉन्स आम्हाला मिळाला. I am really thankful to one and all. It was on the basis of these webinar sessions, we were able to treat timely, and due to timely referral of patients with myocardial infarction, they had the benefit of undergoing primary angioplasties, as well prevention of patients landing up in heart failure and hypertensive heart failure. So I take this opportunity and I would like to begin with our 5th session. आपला आजचा सेशन आहे जे आपण सर्वत्र सगळेच रोज ओपीडीत पाहतो, फीवर. So in this next 1 hour which I'll be talking on, we will discuss about case-based approach to fever. What is fever? We are all aware of fever is nothing but the rise in body temperature above the normal physiological variation. तर आपला normal body temperature, as we all know, it is around 37.4 degrees Celsius, and above that we consider as fever, and also above 99.9 degree Fahrenheit it is considered as fever. So whenever a patient comes to you in the OPD for a case of fever, first question that we ask, ताप कधी येतो? डेफिनेटली पेशंट्स ओपीडी बेसिस जेव्हा येतात तेव्हा पेशंटना 1, 2 or more so 3 days हिस्ट्री ऑफ फीवर असू शकते. सो फर्स्ट क्वेश्चन वी आस्क इज, ताप किती वेळा येतो, दिवसातून कितीदा येतो आणि दररोज येतो का? सो ऑन द बेसिस ऑफ दॅट, फॉर हिस्ट्री टेकिंग ऑफ फीवर, अ व्हेरी सिंपल क्वेश्चन, whether fever is intermittent, it is continuous or remittent. Now as you can see in the slide, intermittent fever is of 3 types. So whether a patient gets fever daily, daroz taap yenara patient, then for example in a case of UTI or abscess or tuberculosis, then tertian fever, patient gets fever every alternate day. आपल्या भागामध्ये malaria is not that commonly found, but then tertian and cotton fever can be found in malarial fevers. Also, what is remittent fever and what is continuous fever? So now we can see patient आपल्याकडे येत असेल, continuously fever आहे for more than 3 or 4 days. So we should have some clinical suspicion. We can suspect if patient is having respiratory symptoms, patient can be a case of pneumonia or patient can have typhoid fever. आता टायफॉइडचा विषय असल्यामुळे it is a appeal to all that usually we tend to send Vidal test in the first week of fever. तर कधी Vidal test first week of fever मध्ये it can come very slightly subtle values can be there, like 1:80 or 1:40. तर हे टायटर्स किती सिग्निफिकंट आहेत हे पाहणं खूप गरजेचं आहे. विडाल पॉझिटिव्ह आलं तर पेशंटचा फीवरचा ड्युरेशन कमीत कमी 5 ते 6 दिवसाचा आहे का हे पाहणं खूप गरजेचं आहे. वी ऑफन गेट मिसलीडेड and mislabel the patient as typhoid fever. So this has to be taken care of. Also, many a times, all of us come across patients who complain of evening rise of temperature. फक्त संध्याकाळचा ताप येतो. So this is very important. It can help us to pick up definitely tuberculosis, which is very, very common scenario in our setup. Now, what can be the causes of fever? It can be, as I already described, infectious. Now, very rare causes which can cause prolonged fever, fever of unknown origin, ज्याला म्हणतो FUO or PO, pyrexia of unknown origin. So that can lead us to some complex diagnosis regarding the etiology of fever. It could be some autoimmune cause, it can be some endocrine cause, and also depending आता कोणत्या एज ग्रुप मधला पेशंट आहे. If it is an elderly age group, and depending upon the associated symptoms, the patient can be diagnosed of some malignancy. Cancer diagnose होऊ शकतो जर elderly patients असतील with prolonged fever. So this history taking of fever, the pattern as we already discussed. Now duration. Usually fever of more than 21 days is called as fever, prolonged fever. Fever of unknown origin म्हणण्यासाठी, PO म्हणण्यासाठी patient has to have a fever of 3 weeks or more. आपल्या भागामध्ये डेंगू is very common. So I would like to describe dengue fever in detail in the upcoming cases. Also now, as we are all very well versed with COVID, with swine flu, and even for that matter, the most latest Zika virus. So travel history has a very important role. And depending upon what symptoms are associated with fever, फक्त ताप आहे का, तापाबरोबर खोकला, सर्दी, रेस्पिरेटरी सिम्पटम्स आहेत का, ॲब्डॉमिनल सिम्पटम्स आहेत का, किंवा पेशंटचा फीवर कॉम्प्लिकेट होतोय का, हे पाहण्यासाठी द मेन थिंग इज वेदर पेशंट इज बिकमिंग ड्राउझी. पेशंट फार झोपतोय का, खूप जास्त वीक आहे आणि पेशंट इज इन अल्टर्ड सेन्सोरियम, पेशंटला ग्लानी येत असेल तर that is very important while taking the history of fever. Additionally, now rash with fever, there are typical rashes which appear on different days after the onset of fever. Very commonly we come across is chickenpox rash. The patient presents to you with fever and rash on the very first or second day. So likewise, there can be rash associated with fever. Now this is a typical chickenpox rash where there are vesicular eruptions on the back, the first figure, in which initially it can be fluid filled and then later they can develop into pustules, that is pus filled vesicles. The second figure which you can see, it is a typical reddish macular rash which is seen in measles, कांजण्या जे म्हणतो. Additionally, now when a patient with fever is coming to us in the OPD, we can ask for baseline investigations, but then we should be aware of when the patient needs hospitalization, when the patient needs to be referred for hospitalization. So the most important thing is persistent fever, continuous fever, and any fever which is not getting explained. आपल्या डे टू डे ओपीडी मध्ये पेशंट आला तर सगळे आपण वी आस्क फॉर अ सीबीसी अँड युरिन रुटीन. सीबीसी इफ इट पिक्स अप सम सॉर्ट ऑफ ल्युकोपिनिया, डब्ल्यूबीसी काउंट कमी असेल किंवा प्लेटलेट्स लोअर साईडला असतील, सो वी कॅन इझिली diagnose some sort of viral infection, viral fever, and then keep on following up the patient. But if we do not get a hint as to what the fever is of, what is the cause of fever, if patient's urine reports, if patient's other relevant findings are also normal, then we need to refer timely. Additionally, we should pick up complications of fever. As I already told, we will be discussing on the complications of dengue fever case wise. So another thing which we need to suspect is patients who are coming to you, if they are already diagnosed cases of malignancies. बरेच पेशंट्स जे किमोथेरपीवर असतात ते आपल्याकडे फॉलोअपला ओपीडीत आले तर त्यांचा फीवर मे नॉट कोरिलेट एक्झॅक्टली विथ द अमाउंट ऑफ सिम्पटम्स दे आर टेलिंग, बिकॉज मेनी अ टाइम्स patients on chemotherapy may have very low grade fever, but then they can be in sepsis. Also in the elderly age group, fever may not get correlated to the amount of sepsis, the degree of sepsis which they may be suffering from. And there are some very rare causes which can lead us to the diagnosis of some autoimmune diseases. Before I start these cases, let me tell, all these cases have been referred to us in the last 4 or 5 months, and these were referred either in a very poor general condition or maybe even at a tertiary referral center, and that's why some of the learning lessons which could have been picked up initially during the earlier days of fever have been discussed in each of these cases. So let me begin with a case of fever with rash. आता हा पेशंटचा ICU मधला फोटो आहे, but when the patient went to the general practitioner, the patient had only 2 to 3 days history of fever. We can see he is a young 24-year male. तो गेला आणि त्याला टिपिकली वॅरिसेला झुस्टर म्हणजे जे आपलं चिकन पॉक्स रॅश आहे तशी रॅश होती, आणि अँड ही वॉज स्टार्टेड ऑन ट्रीटमेंट विथ वॅलसाइक्लोव्हिर, and he had these multiple blisters which went on increasing over the face and the trunk, and then it was sudden in onset and all progressive as expected in a typical case of chickenpox. But this age group, as we can see, is usually a late presentation. This patient did not give any history of prior chickenpox history in the childhood. आताचा जर ट्रेंड पाहिला तर we can see that in the immunization schedule for pediatric also varicella has been included. So आता हा आपल्याला माहितच आहे की चिकन पॉक्स एकदा झाला तर तो इट रिमेन्स डॉर्मेंट इन द बॉडी फॉर नेक्स्ट 3 to 4 decades, and so after 4 decades now again we have to suspect it can re-erupt, and that time it is in the form of Shingella infection. And so now as we know, many diabetic patients, they have been US FDA has approved the immunization of all diabetic patients with Shingrix vaccine. So chickenpox vaccine, ideally we can call it as herpes zoster vaccine. So after the 4th decade of life, if you get a herpes zoster infection, so it can be prevented in immunocompromised patients with the vaccines. Now this case, as we see, patient young male होता, chickenpox diagnosed झाला होता, वॅलसाइक्लोव्हिर चालू केलं होतं. When we got this patient in the ICU, now what went wrong is this patient was extremely breathless. Patient खूप डिस्निक होता आणि पेशंटला हिमॅच्युरिया झाला होता, and he was still, though breathless, he came walking to the ICU, but he required O2 support later, and consequently his clinical condition started worsening. So now he has come with a deranged coagulation profile, thrombocytopenia, leukocytosis. So what has happened, as we can see in the investigations, this patient is in gross sepsis. He has very severe leukocytosis, 44,900 count, WBC count. He has thrombocytopenia, 1,17,000. And in addition, we can see that the liver enzymes, SGOT and SGPT values are almost nearby 3,000 and 2,000. So it is far above the normal, and it indicates acute liver injury. कधी लिव्हर LFTs डिरेंज होताना पहिला ट्रान्स अमायनेटिस होते, म्हणजेच SGOT SGPT डिरेंज होतात, आणि मग नंतर नाव वेनेवर वी हॅव एनी केस ऑफ लिव्हर इंजुरी, लिव्हर फेल्युअरचा कोणताही पेशंट असेल, जर त्याचा PTINR व्हॅल्यू, दॅट इज नाव ॲज वी कॅन सी इन दिस INR इज डिरेंज्ड, म्हणजेच कोॲग्युलोपॅथी डेव्हलप होत असेल तर इट इज अ व्हेरी अलार्मिंग साईन. तर हा पेशंट जो चिकनपॉक्स डायग्नोज्ड आहे, he is coming to us with liver failure, acute liver failure in sepsis, and as I already told you, he was breathless. So what was it? This was the X-ray which was at the time of presentation, 2 to 3 days. In fact, 2 to 3 days after presentation, initially he required mild O2 support, but then later his oxygen requirement increased quite significantly. Now if we see if something was missed during the OPD days of this patient, we can find that on detailed inquiry this patient has been given methylprednisolone. So आता हा patient steroids receive करत आहे. As we know, varicella zoster infection is in viral infection, and in that if you give steroids to the patient, it is going to flare up the infection in response to the immune system, immune response of the body. So, and we can also find that the sister was also having this varicella infection. She also had some sort of a rash 10 days ago. So then, whenever a patient has come to us with some viral infection, steroid should never be given, because it can flare up the infection and promote the complications of the infection, as it happened in this case. So this was a final diagnosis, as I told, varicella zoster, which could be self-limiting initially, but unfortunately this patient developed ARDS with acute kidney injury and acute liver injury. So this was a case of fever with rash. Now, whenever we have patients in the OPD, we should definitely learn to categorize them. फॉर एक्झाम्पल, आपल्या ओपीडीत बऱ्याच वेळा पोस्टपार्टम और प्रेग्नेंट फिमेल्स येऊ शकतात. जसं एल्डरली एज ग्रुप इज अ व्हेरी हायली ससेप्टेबल ग्रुप. Postpartum ladies are as well as pregnant females should be considered in the high risk zone. So whoever wants to take a screenshot can take the screenshot for this. Some details of varicella zoster infection before we proceed towards the next case. So these are some of the details regarding varicella zoster infection, and this is regarding the diagnosis, treatment and prevention. For prevention in adults, as I already have given the details of the immunization for adult patients, especially diabetic patients. So now these complications should be kept in mind when the patient is being treated on OPD basis. Skin infections, neurologic complications, Ray's syndrome, pneumonia and hepatitis. So coming to our next case, a fever patient with a postpartum lady is coming to you in the OPD and she's complaining of fever. खूप कॉमन सिनेरिओ असतो. आणि आपण पाहिलंच असेल की पोस्टपार्टम फिमेल्स दे आर व्हेरी व्हेरी रिलक्टंट फॉर गेटिंग एनी इन्व्हेस्टिगेशन्स or anything immediately, because they are very very busy with the babies, with the newborns. So this becomes a very tricky and this situation for us, because only on the OPD basis we need to pick up things. आता पेशंटला ॲब्डॉमिनल पेन, माइल्ड फीवर, सम वजायनल symptoms असतील, then definitely if the patient has undergone a section, LSCS, then pertaining those symptoms, we need to be alarmed and we need to refer the patient to the gynecologist. But if the patient comes with other system involvement, now for example, this lady, 36-year-old lady, she has come to us with fever of 5 to 6 days history postpartum, last 3 months, and then she has cough of 2 to 3 days and severe generalized weakness. So on OPD basis, patient was examined. This patient is having severe tachycardia. So many of these patients will be anemic in our setting. So this also has to be evaluated. Why patient is having so much of tachycardia? Probably because of she was febrile at this point of time. But then about her labs, everything looks quite normal. There is no any derangement of CBC, the LFTs, RFTs, everything look to be pretty normal. Then definitely she was getting fever for 4 or 5 days. One of our colleague doctors only had referred this because everything was normal to look. Chest X-ray normal hota, UHA abdomen normal hota, but then she's getting fever, which is worrisome. Now, as we all know, so many patients of swine flu and COVID. So we all are well aware of this panel. So we send this, and it covers all the influenzas and all the viral infections which are very commonly found, especially in the rainy and winter season. But everything was negative. Which influenza, H1N1, COVID, everything was negative. So then why she's getting fever? Okay, even if there was no bicytopenia, thrombocytopenia, we just did her viral markers, everything was negative. Malaria, negative. Now, after 7 days, even her Vidal was sent, and that was negative. So, blood culture has to be sent. Now, what is the importance of blood culture? It is a request to all the colleagues की पेशंटला IV antibiotics OPD basis चालू करण्याआधी it is very advisable to send the blood culture because it helps a lot in cases, especially in cases who have more than 1 week of fever. Also, before empirically starting any IV antibiotics, antimalarials, for a fever of more than 1 week, blood culture should definitely be sent. So now this patient, I'll come back to the case. She has been, her blood culture has been sent. Her echo was normal. And then at this point, we started on IV Monosef 1 gram BD. And considering the possibility of tropical fever, still tablet doxycycline 100 milligram BD was started. And she was additionally started on antimalarials empirically. But the patient had persistent fever. So again, now we sent her fever panel as well. So rest, whatever profile is left, chikungunya, rickettsia, salmonella, everything turned out to be negative. But this patient, there is a catch in this patient. When I'll go back to the slides where we did her general examination. So in this general examination, what is missing? Our typical examination of pallor, edema, lymphadenopathy, icterus, clubbing, cyanosis. So the mnemonic, which is police, is missing over here. So this patient was having a very small lymph node in तिच्या नेक मध्ये lymphadeninitis होतात, swelling होती. So every patient with fever, especially postpartum patients or immunocompromised patients, we have to see whether there is any neck swelling for a patient with fever with no other clinical sign which is going along. So now this patient's lymph node was FNAC was done, needle घेऊन FNAC केली होती आणि here as we can see this acid fast bacilli came to be positive. So this is for ZN stain, जे झील नेल्सन स्टेनिंग करतो आपण, एकदम बेसिक टेस्ट for diagnosing tuberculosis. This turned out to be positive. So what next? Immediately we started the patient on AKT. Now after starting AKT, as we are all aware, सगळे पेशंट्स जे कुठल्याही फॉर्म ऑफ ट्युबरक्युलोसिस डायग्नोज होतात, they come to you for later post discharge. You have to screen them for jaundice. त्यांची LFT चेक करणे खूप खूप गरजेचं असतं. For the next 2 to 3 weeks they can develop jaundice, so that has to be kept in mind. And in addition, now she is a postpartum lady. She will definitely ask you whether I can feed the baby. So the answer should be yes, we can definitely feed the baby, but at the same time you should advise that the baby has to be screened for tuberculosis and has to be referred to the pediatrician, because usually they are started on isoniazid. And in addition, also before starting the AKT, as all the physicians, the patient's eye examination has to be done, and additionally LFTs have to be monitored. So this was a case of a fever in a postpartum lady which turned out to be tubercular lymphadenitis. So just if you want to take the screenshot, TB in pregnancy and postpartum period, a short review about it. Also, we should be aware that tuberculosis can recur not only in lymph nodes, it can be pulmonary, extrapulmonary, and everything, any body part, including the nail, can be infected with this tuberculosis. So that has to be kept in mind. A very, very common scenario in our Indian setup. Now coming to the main cause of fever, which we see day in and day out, at least in our area, it is not at all affected by any season. I am sure you all must agree, डेंगू आपल्याकडे इन अँड आउट येतच राहतात. तर आता डेंगूचा पेशंट टिपिकली येतो, फीवर फर्स्ट 2 or 3 days. डेफिनेटली फॅमिली मेंबर्स ऑल्सो गिव्ह अ सिमिलर हिस्ट्री. एखाद्याला पेशंटला घरी डेंगू झाला तर इतर बऱ्याच लोकांना होतो. मग सर्वांना कॉज देखील माहित आहे. वॉटर पॉट्स, वी डोंट नो, इट इज रेनिंग एव्हरी डे, वी डोंट नो विच सीझन इज रेनी सीझन. We are like having rains throughout the year. So then this risk remains. Now, in addition, these symptoms can be present. Patient can have severe body ache, severe myalgia. बरेच पेशंट रेट्रोऑर्बिटल पेन, डोळे दुखतात, डोकं दुखतात असं म्हणत राहतात. Additionally, there can be conjunctivitis. Patient can have extreme fatigability, loss of appetite. Some can have associated abdominal pain and diarrhea. आपण पाहत असतो की बरेच डेंग्यूचे पेशंट डायरिया म्हणून पण घेऊन येतात अँड देन इन्सिडेंटली वी सी द प्लेटलेट्स आर ऑन द लोअर साइड. Now, the alarming thing in dengue, which we have to be very, very aware, is when to pick up clinically, when the patient can go into complications. Now, if we look at dengue fever, we know the culprit. It is the tiger mosquito. Tiger mosquito, the Aedes aegypti mosquito. As we know, it is rightly called the tiger mosquito because of the tiger-like stripes which are present on it. And this symptoms, as we have already discussed, but the symptoms of complication should be very timely picked up, which mainly includes hypotension. Now, this sign of hypotension and bradycardia, alarmingly we have to be aware of. बरेच पेशंट्स, डेंग्यूचे पेशंट्स स्वतःच आपल्याला सांगतात की आम्हाला सलाईन द्या डे केअर बेसिस अँड वी विल बी गोइंग होम. In fact, rather than we treating them, they themselves ask for this sort of hydration therapy. So, which is very right. So, the patient has to be well hydrated in dengue. There is no specific treatment for dengue, and the treatment is only symptomatic, and prevention of complications is very, very important. So, when the patient develops hypotension or bradycardia in your OPD, you notice the patient is having bradycardia especially. Dengue myocarditis should be kept in mind. हे कॉम्प्लिकेशन खूप कॉमनली वी कम अक्रॉस. आणि त्याच्यानंतर जर पेशंट सांगत असेल एक्स्ट्रीम हेडेक होत आहे, खूप डोकं दुखत आहे, किंवा पेशंट थोडाही अल्टर्ड सेन्सोरियम मध्ये आहे, ड्राउझी आहे असं वाटत असेल, डेंग्यूचा पेशंट, ऑलवेज डेंग्यू एन्सेफेलायटिस हॅज टू बी केप्ट इन माइंड. डेंग्यू एन्सेफेलायटिस इज व्हेरी व्हेरी इम्पॉर्टंट टू बी पिक्ड अप बिकॉज मेनी अ टाइम्स डेंग्यू एन्सेफेलायटिस एकदा डेव्हलप झाला and patient lands up in complication of dengue encephalitis, it is irreversible. So it is very important to pick it up. In addition, we are all aware of the commonest complication of dengue shock syndrome ज्याला म्हणतो आपण. So hydration is very, very important in these patients. So now this is a typical case of dengue rash, the petechial rash which we can see, and also now the last season of dengue, we came across many patients who presented with acute liver injury. So, बऱ्याच patients HOT, SGPT levels were pretty highly raised. We had a few cases where patients developed fulminant hepatic failure. Patient होता डेंग्यूचा पेशंट आला, पेशंटचे प्लेटलेट्स कमी होते, बरेच patient was transfused with RDP, SDP as per requirement. But the main troubling thing was acute liver failure, which went on progressively developing. Patient finally landed up in coagulopathy and DIC. So let us have a look at this interesting case. 53-year-old male. He came to us with fever, with chills, generalized body ache. Already the patient was diagnosed of dengue NS1 positive. Also, one more thing I would like to add is, whenever we ask for a dengue test, see to it that we send the dengue antibody and NS1 test after 3 to 4 days of onset of fever. Otherwise, many a times it comes to be negative. जर तुम्हाला डेंग्यू खूप स्ट्रॉंगली सस्पेक्ट होत आहे आणि पाठवायचंच असेल तर वी शुड गो फॉर डेंग्यू PCR, which can be positive earlier than these antibodies. So then this patient was having severe bicytopenia, as we can see, WBC 2500, platelets of thrombocytopenia 70,000. And now आता आल्यानंतर 2 ते 3 दिवसात patient started complaining of abdominal pain. In fact, patients baseline LFTs were sent, and these were SGOT was 475, SGPT was 130. So now at this point of time, we start hydrating the patient and keep on monitoring the platelets. In addition, now this patient developed progressive thrombocytopenia. So he underwent transfusions for the same. But at the same time, patient started developing altered sensorium. So what next? Why altered sensorium in him? So definitely again dengue encephalitis component has to be ruled out. So basic neuroimaging has to be done at this point of time. But what since it was negative in this, we had to reassess the liver function tests. And as we can see, this is progressively increasing. His HOT went on increasing up to 11,000, and he finally was in a case of something called a shock liver. So we can see that it has jumped as high as 11,000, which is a very, very remarkably high figure. This was one of the cases which we had last month. And this patient, we had the fear of that the patient would go in fulminant hepatic failure. So it was very important to treat this patient. We treated as in any other acute liver failure. Acute liver failure ची treatment हीच करावी लागते, डेंग्यूने झाला असू दे or whatever. Acute liver failure चा पेशंटचा treatment regimen follow केला जातो. So that includes N-acetylcysteine. If anybody wants to take a screenshot of the exact criteria, so we can see that initially there is transaminitis, later the bilirubin levels go on increasing, and still initially if the patient develops hepatic encephalopathy, it is still reversible in the initial stages. Some of the patients land up in chronic liver disease. थोडे patients याच्यातून बाहेर येऊन chronic liver failure मध्ये जातात. थोडे absolutely they can come back to their they can have normal LFTs and it can be baseline normal again. And some we have also lost one case due to acute liver injury and fulminant hepatic failure. So it can have a wide spectrum. We can take a snapshot of this. So now what is the treatment? If a patient lands up is getting coagulopathy, जर पेशंटचा PTINR डिरेंज झाला तर त्याचं only specific treatment of choice remains liver transplant. So then we should have an alarming sign, and we should refer the patient for a liver transplant as early as possible in such cases. For that matter, कोणताही पेशंट acute liver failure चा पेशंट जर coagulopathy develop होत असेल, if PTINR is getting deranged and there is a possibility that this patient can have irreversible liver injury, then it has to be timely referred for liver transplant. As we all know, liver transplant is now very readily available modality for us. So the patient should be given benefit for that. Additionally, in this case of acute liver failure where the HOT, HPT were up to 11,000, that time we treated the patient with plasmapheresis. तर हे प्लाझ्माफेरेसिस काही नाही पण एक प्रकारचा हिमोडायलिसिस असतो ज्याच्यामध्ये प्लाझ्मा दिला जातो, विच we called as plex, which is done for many other indications. I'll not go into the details. And this patient very positively responded to plasmapheresis, and we were able to salvage his life and reverse his liver injury, and this patient did well. So a timely intervention was also useful in this patient. So this was the case of acute liver failure. This is a protocol. Though it is dengue related protocol, the protocol remains the same for all patients with acute liver failure. We treat the patient with anti-encephalopathy measures. We do treat with N-acetylcysteine, though its role is not very proven. And also patient can undergo a plasma exchange before he is finally subjected to a center where there can be liver transplantation. So now, considering this dengue with liver failure, which we came across, we had many patients in this season. Dengue encephalitis and dengue myocarditis also have to be kept in mind. आता dengue myocarditis, just to have a word about it, जर पेशंटला ब्रॅडिकार्डिया असेल किंवा पेशंटला हार्ट फेल्युअरचे सिम्पटम्स होत असतील फीवर डेंगू फीवरच्या पेशंटमध्ये, तर डेंगू मायोकार्डायटिस शुड बी केप्ट इन माइंड. पेशंट शुड इमिजिएटली अंडरगो अन इकोकार्डिओग्राफी आणि NT-proBNP ही टेस्ट पाठवली पाहिजे. सो दॅट इज द टेस्ट ऑफ चॉईस which can help us to differentiate whether it is the etiology is dengue or for other etiology has to be screened consecutively. Now additionally, fever with acute diarrhea, this is our case 4, a very common setup. कितीतरी पेशंट्स day in and day out they come with gastroenteritis. So now if the patient is having some sort of infective gastroenteritis, he'll have subtle low grade fever. And now we had this patient, हा पेशंट 72 year मेल, प्रत्येक गॅस्ट्रोएंटरायटिसचा पेशंट खूप अलार्मिंगली चेक करावं लागत नाही. बट नाव इन दिस केस 72 year मेल आहे. ॲज वी ऑल नो, पिडॅट्रिक आणि एल्डरली एज ग्रुपमध्ये इवन फ्यू लूज मोशन्स द पेशंट कॅन लँड अप इन सिव्हिअर डिहायड्रेशन. सिव्हिअर डिहायड्रेशन होतो, पेशंट गोज in shock within no time, hypovolemic shock, and has to be treated aggressively with IV fluids. In our ICU, we constantly keep on checking the IVC and administer fluids. And believe me, in cases of acute diarrhea, now as we have all faced a few months ago, there were a lot of cases of cholera. So this was one of the interesting cases which we came across. He was a 72 year male who had fever, diarrhea, extremely dehydrated, and only 1 or 2 days history of loose motions, but the frequency was too high. And this patient had typically rice watery stools. He described watery diarrhea, and then he had cold extremities, and he was in shock when he came to us. So initial 3 to 4 hours, पेशंट शॉक मध्ये गेल्यानंतर पहिल्या 3 ते 4 तासात how we hydrate, that definitely has a very pivotal role in deciding whether the patient will land up in other complications like acute kidney injury and further complications. So that is very important. And also now this patient was aggressively treated with IVC monitoring continuously, and we can see that the creatinine was raised already 2.16. As I told you, the significance of hydrating the patient very aggressively, we can see that if we hydrate very adequately, even the creatinine levels, if they have developed acute kidney injury, also do come down in the consecutive days. So now this is definitely not urine sample. This is the sample of our cholera patient who had this sort of typical rice watery stools, very thin. तर आता हे कॉलेरा डायग्नोज करणं गरजेचं आहे. आपण जेव्हा फर्स्ट स्टूल रुटीन एक्झामिनेशन साठी पाठवतो, त्याच्यामध्ये इफ पेशंट इज नॉट हॅव्हिंग सो मच ऑफ वॉटरी स्टूल, देन वी कॅनॉट आस्क फॉर हँगिंग ड्रॉप प्रिपरेशन. सो हँगिंग ड्रॉप प्रिपरेशन जे कॉलेरासाठी टिपिकल टेस्ट आहे, that has to be, now this patient as we can see was positive for darting motility. काय असते ही darting motility? Hanging drop preparation is screened under the microscope. म्हणजे patient if he is having very watery stool, it has to be immediately sent to the lab, and then we have to see under the microscope, the microbiologist can see the darting motility of the movement of the Vibrio cholera, which is a very great thing to watch microbiologically. Now this patient was treated definitely with antibiotics in the form of doxycycline. Doxycycline plays a role. For OPD basis, if you suspect cholera, it is important that the doctor themselves, the ones who are exposed themselves, need to be given 300 milligrams of stat doxycycline oral. So if you are strongly suspecting cholera, or if the hanging drop preparation is positive and you have a report in hand, you should tell all the other relatives to take at least stat dose of doxycycline, if not contraindicated for any other matter. Additionally, the patient has to be treated with probiotics. The urine output monitoring has to be done every hourly, and other than this, the patient has to be treated symptomatically for abdominal pain, and once the acute kidney injury starts resolving, the patient can be initiated orally. And so this is about cholera. We can have a screenshot regarding the organism, Vibrio cholera, the clinical features of cholera, and so this has to be picked up. There is decreased skin turgor and sunken eyeballs. डोळे आत गेलेले असतात. Typically the skin turgor is lost. And as I previously told, the pediatric age group and the elderly age group, this has to be picked up earlier. Also, some patients can have severe electrolyte disturbances, and they can present with muscle cramps. Their labs can show dyselectrolytemia in the form of hyperkalemia, and additionally AKI, renal failure. So now the degree of hydration has to be assessed. So whenever a patient comes to the OPD to us, even with only mild dehydration, it has to be picked up. But if you suspect moderate or severe dehydration, if the patient is having postural hypotension, tachycardia, it is moderate dehydration. आणि पेशंट खूप लिथार्जिक असेल, ऑलमोस्ट व्हेरी इरिटेबल or semi-conscious, then the total body water loss of more than 10% has to be picked up and it has to be categorized under severe dehydration and then referred. So now this is the treatment. You can take a screenshot for the treatment details. So now antibiotics, as already discussed, doxycycline has to be given. Sometimes if doxycycline is unavailable, as it can happen sometimes, 1 gram azithromycin single dose also may be given in such cases, or erythromycin 250 milligram for 3 days. So prevention of cholera is very, very important. Once we come across cases of cholera, we have to keep on alarming everybody and keep them aware. ही बेसिक गोष्ट असते की हात धुणे, हात स्वच्छ धुतले, स्ट्रीट फूड अवॉइड करणे, रॉ व्हेजिटेबल्स किंवा फ्रुट्स खात असताना स्वच्छ धुवून घेणे, हे सगळ्या गोष्टी असतात. पण जेव्हा कॉलेरा चा साथ येतो तेव्हा ह्या सर्व गोष्टी पुन्हा पुन्हा बंबार्ड करून पेशंटच्या नातेवाईकांना सांगणे, बिकॉज बाय टेलिंग दीज सिम्पल instructions of hand hygiene, and we are preventing lot many other cases. Also, as you must have experienced in the summer seasons, if at all there are cases of cholera, patients have to be asked whether they have a history of swimming in a specific swimming pool, or for that matter जर तलावात पोहायला गेले असतील तर that has to be screened, and patient awareness has to be created for the same. So we'll go to the next case. This was a case of fever with abdominal pain. बरेच पेशंट्स आपल्याकडे येतात, पोट दुखते. तर आता पोट दुखते हे खूप वाईड स्पेक्ट्रम कंप्लेंट आहे. So depending upon, we do palpate the patient in the OPD, and then we see where the patient is having pain, in which quadrant. So now we had this patient who was a 38-year female, and she had right upper quadrant abdominal pain, and she had a history of travel to a rural area. कोणत्या तरी गावाला गेली होती, खेड होतं, आणि तिथून जाऊन आल्यानंतर तिला फीवर यायला लागला, आणि राईट टिपिकली शी केम विथ राईट हायपोकॉन्ड्रिक टेंडरनेस, and she was having fever, she was febrile, and she was having tachycardia. And now, as I told, in which quadrant the pain is, समजा राईट हायपोकॉन्ड्रिक रिजन असेल, पेशंट मे बी going develop, there may be development of some sort of hepatitis. The patient can complain of right hypochondriac pain. Lumbar region pain, right आणि left दोन्ही असतील, typically loin to groin pain असेल, तर we should definitely keep in mind obstructive uropathy, ureteric calculus असू शकते. Additionally, right iliac fossa tenderness, we are all well versed with acute appendicitis patients. They'll always come with right iliac fossa tenderness. And also epigastric pain has to be kept in mind. It can not only be related to GERD or acid peptic disease, फक्त ulcer related नसेल, पण cardiac patients can come with epigastric pain. Myocardial infarction चा patient हा epigastric pain घेऊन येऊ शकतो. So along with fever, if there is abdominal pain, the other acute abdominal causes have to be kept in mind while treating the fever. So immediate investigation which you will ask for is USG abdomen. So likewise, this patient also underwent USG abdomen, and then there were such findings that we had to immediately send the patient for a CT abdomen. So now this patient's investigations were done, and the main CT image, if you can see this transverse section of CT abdomen, we can see this hypodense lesion in the right lobe of the liver, which we can see. It is suggestive of an abscess. So this is a case of liver abscess. Liver abscess ची केस पाहिली तर we always have to keep in mind the commonest cause, amoebic liver abscess, म्हणजे amoebic infection होतं, त्याच्यामुळे liver abscess होऊ शकतो. So this can be a very common scenario. In this, patient complains of daily fever spikes. दररोज पेशंटला ताप येत राहतो आणि पोटात दुखत राहतो. So this case was referred to us, and typically this patient, ह्याला अँकोवी सॉस पस म्हणतो आपण. जेव्हा पेशंटचं डायग्नोस्टिक किंवा थेरपेटिक पिगटेल कॅथेटर घालून जेव्हा ड्रेन केलं गेलं, तर टिपिकली दिस अँकोवी सॉस एक प्रकारचा सॉस आहे. इट इज ब्लड टिंज पस, and it is very typical of diagnosing amoebic liver abscess. So this was diagnosed after the CT. The patient underwent pigtail catheter drainage, and then depending on this, the patient was started with metronidazole. The treatment is very simple, metronidazole IV, but sometimes only IV metronidazole will not help, and as in this patient, immediately after pigtail drainage, the patient gets symptomatically very much relieved, and that is definitely helpful. And the drain has to be kept in situ till it comes to at least minimum level of 10 ml, and then it can be removed. And some patients may not have response to metronidazole, so those have to be given duloxetine. They may keep on getting fever in spite of pigtail drainage and everything, so then they do respond to duloxetine. So this was an interesting case of amoebic liver abscess. Coming to the next case, many a times we may not have find for time for development of complications, and patient may present to you with a convulsion. So this patient came to us with convulsion. He was just a 17-year-old male, 17 वर्षाचा मुलगा होता, आणि he complained of severe headache. The history was also very short, only 2 to 3 days history of severe headache. And then when he came to the doctor, to the OPD, he threw a convulsion, a generalized clonic full-blown seizure. So he had tachycardia, and then the patient definitely, when he came to us, was loaded with levetiracetam loading dose, and then he was in the post-ictal phase and sent to us. So then now this was done immediately. Neuroimaging was done within 2 to 3 hours of his admission, and what you find, हे काय दिसते, एक this is called a scolex. आता हे scolex काय असते? It is you can see a ring enhancing lesion as in the center. You can find only one scolex. हे कसं असतं? This is a type of a calcified calcification which is surrounding the organism. हा एक जंत आहे जो ब्रेन मध्ये सापडतो. It happens rarely, but it can be a very common scenario in our setup. Now this young male, त्याने नॉनव्हेज खाल्लं होतं. तर नॉनव्हेज तर तुम्ही म्हणणार कोल्हापुरात तांबडा पांढरा सगळं फेमस असते, नॉनव्हेज तर सगळेच खातात. देन व्हॉट वॉज सो स्पेसिफिक दॅट वी आस्क्ड फॉर दिस हिस्ट्री? तर आपल्याकडे जे पेशंट्स असा सिनेरिओ घेऊन आले, इफ देर आर सम रिंग एनहान्सिंग लिजन्स इन द न्यूरो इमेजिंग, तर दिस पेशंट had history of consumption of pig in the recent past, and this organism, as I told, scolex formation was because of cysticercosis. हे जे जंत आहे टेपवर्म, टिनिया सोलियम वॉज आयसोलेटेड, आणि ते ब्रेनला अफेक्ट करत असल्यामुळे त्याला न्यूरोसिस्टिसर्कोसिस असं म्हटलं गेलं. तर ओनली हिस्ट्री ऑफ फीवर विथ असोसिएटेड सिम्पटम्स कॅन लीड अस टू सो मेनी rare and diagnosis, and as in this patient, and it is very interesting to know that he had a history of pig consumption. आता जर I'll not go into the details of this life cycle, पण इथे सेंटरला आपल्याला एक पिग दिसतोय. तर ते इंटरमिजिएट होस्ट असतं, म्हणजे हे जंत जे आहेत टिनिया सोलियम, ते पहिला पिगच्या पोटात गेलेले होते, आणि पिग त्या मुलाने कन्झ्युम केल्यामुळे त्याच्या पोटात जाऊन त्याच्या ब्रेन पर्यंत गेले थोडक्यात. So then this costed him convulsion. So it has to be kept in mind that such rare these things can happen, neurological diseases. In fact, this is an example of a CNS infection case, fever with convulsion. So this was treated with antiparasitic regimens. या पेशंटचं स्टूल एक्झामिनेशन देखील केलं होतं, which was not having any ova or cysts. And then this has to be given prolonged, and patient has to be treated with albendazole. And asha patient la we keep on doing the neuroimaging repeatedly. We have to repeat it for 3 to 6 months, so that it has the organism has to be completely eliminated from the body. So coming to the last case, we all are aware of various new strains of COVID. So आपण आता कोविडच्या बऱ्याच नवीन स्ट्रेन्सना रेझिस्टंट झालो. त्याच्यानंतर आपण स्वाईन फ्लूला देखील रेझिस्टंट झाला आहोत. तर एकच राहतो तो मी डिस्कस करेन, विच वी केम अक्रॉस इन द ओपीडी. This pregnant female had come to us, 32-year-old pregnant 5-month ANC patient. She has traveled to Middle East Asia and she has come to us with fever, severe headache, generalized weakness. And then she was, because being pregnant, she was screened in that period for all the viral infections. Her entire fever panel was negative, but her Zika virus came to be positive. So we had this patient OPD basis, we had referred accordingly to the higher centers for further this. Then now this Zika virus ha now kasa आला तर Zika forest in Uganda. There some monkeys initially had developed this. They were the intermediate host for development of this viral infection. And then it is very, the pregnant females are very susceptible to this viral infection. And so this is an arbovirus. And also, as I told, this is of very, has to be screened very vigorously in pregnant females, because if the pregnancy is continued in the setting of Zika virus infection, there is a risk of abortion, premature births, and very commonly this microcephaly. Bala's brain, small sized brain is seen in the neonates. So it is very important to pick up. And the symptoms are typically fever with rash, headache, joint pain, and red eyes. And the tropical fever panel will definitely pick up this infection. There is no specific treatment of this, but the CNS complications have to be prevented, and those are usually irreversible if they develop. The other treatment form includes supportive care in the form of antipyretics and analgesics. So here I think I have been able to cover almost 7 cases pertaining different body systems. We have learnt about cases with fever with rash. We learnt about dengue complications. We learnt about how the patients who have immunocompromised status, like pregnant patients, postpartum patients, can develop infections, especially tuberculosis, has to be alarmingly kept in the mind. And additionally, on the OPD basis, we have to pick up the possibility of development of complications and prevent those complications. And so I think I have tried to cover as many cases as possible in this period of time. And definitely, I think, I hope this lecture will be useful for one and all, for our daily case-based approach for fever. And I hope this can help us to develop a fever algorithm in our own unique way, and we can treat the patients in a better way. So last but not the least, I want to thank everybody for the constant support. And as I already told, on behalf of Apple Education Life, I extend thanks to one and all for patientful listening of all our sessions. So I would like to end this 5th session on case-based approach to fever. Wishing you all a very, very happy Diwali. So thank you.